Okay, calling to order the Joint Committee on Ways and Means and Health and Human Services. So we're supposed to hear from Department of Human Services, but we're going to reschedule that info briefing and we'll go straight to Department of Health. Because there's just too many questions for Department of Health, so we needed to figure out when we could reschedule Department of Human Services. So with that, good morning.
Good morning, Chair Dela Cruz, Vice Chair Moriwaki, Chair San Buenaventura, other committee members. Thank you for having us here today. I'm Dr. Kenny Fink, the Director of the Department of Health. I'm with First Deputy Val Cato, Deputy Director for Behavioral Health, Marion Suji, Deputy Director for Environmental Health, Kathy Ho, and Deputy Director for Health Resources, Debbie Moriwaki, as well as a number of other staff to support answering your questions if necessary. I will just try and jump in and go quickly through this and hopefully trying to answer some of your questions. Okay. So the state constitution actually has Article 9 that the state shall provide for the protection and promotion of the public health. And from this is really our mission at the Department of Health to protect and promote the physical, psychological, environmental health of the people of Hawaii. And we do that through assessment, policy development, and assurance, which follows the CDC's framework for the 10 essential public health services. Our vision is that all Hawaii residents have a fair and just opportunity to achieve optimal health and well-being. So shortly after starting in this role nearly a year ago, these were the priorities that I came up with. Caring for our team, be a trusted source of information, and you can see the rest of that. And upon reviewing that, those remain our priorities as we go through this. Okay, over this past year, there have been a number of crises that we have need to respond to, including the Hawaii Life Flight incident that occurred, the COVID-19 pandemic, Red Hill, Maui wildfires, and the state-operated specialized residential program incident. And I'll give a little bit of information on each of these. The Hawaii Life Flight mishap. So air ambulance is market-driven. Essentially, the FAA looks at air ambulance as an airline. And currently, the state does not have any contract with air ambulance. So it really is whatever vendor comes into the marketplace. There was a mishap that occurred in December 2022 and did result in the grounding of the fixed-wing aircraft. But there still were some rotor. But even they, with their use, were down for maintenance. So we did partner with the Hawaii National Guard and also the Coast Guard to assist to ensure that the critical transports were able to continue. The Hawaii Life Flight has returned to full operations. But what this revealed to me was that there's just a vulnerability of statewide air ambulance. So we did introduce an administration bill this session to talk through some options for how we could potentially strengthen and stabilize the air ambulance system for the state. We're still, in a pandemic for COVID-19, although the public health emergency ended in March 2023. We remained very active. Some notable events, in addition to the ending of the PHE, was the commercialization of vaccine and treatment, which meant that instead of being paid primarily by government, it's now being initially paid by commercial insurers. So that was a transition that occurred. We continue to remain very active in tracking surveillance, wastewater testing and reporting. We still maintain a website. So this was a snapshot from, I think, last week when I took that. Following the holidays, COVID cases are up. So we're still dealing with COVID, very much so. Some additional ongoing surveillance type work that we do. The left is an indicator of vaccine. And the bottom kind of dark purplish squares reflect those that have received the most recent vaccine. The data may not be complete because, again, it's now coming from commercial covered vaccines. But only 14% of folks, according to our data, have received that vaccine. So we still encourage those, particularly at high risk, to get vaccinated if you've not been vaccinated in the past 12 months. The right is the variant map. And as you shift to the right, that's the more recent report. And the growing size of the box is its share of that particular variant. So you'll see kind of that bottom right, that darkish blue variant is now the one that is taking over the most share. That variant is HV1, which seems to not be the variant on the mainland, which is JN1. So for whatever reason, we're having a different variant. So we're keeping an eye on that, but we are not seeing any indication of increased severity or bad outcomes. Looking at the number of hospitalizations for COVID that are being reported still is stable, although we might see some uptick just because of the increase in cases. Okay, moving on to Red Hill. The Department of Health issued an amended emergency order on May 6, 2022 to the Navy to defuel, permanently close the Red Hill bulk fuel storage facility. Now, to prepare for the safe and expeditious defueling, the DOH Solid and Hazardous Waste Branch needed to provide the necessary oversight to ensure that that would occur safely. We pushed the Navy or Joint Task Force to increase their timeline, but make sure it was safe. But then that work also fell on the Department of Health staff to review in a tight timeline all the work that needed to occur. So they reviewed hundreds of quality validation reports for repairs, participated in weekly coordination meetings with Navy and EPA, and participated in many spill response exercises. But as a result of the team's efforts, 5 months earlier than the initial timeline, 104 million gallons were removed. We continue to be active in monitoring the drinking water and to oversee the facility closure and aquifer remediation. Okay, in response to the Maui wildfires, we activated our Department Operations Center. The Department of Health had the lead for ESF 8 and ESF 10. There's lots of content that we needed to disseminate. One of the ways was by creating this new website where we made information available. We also tried to use other media. Information was translated to get as much information as we could out to the public. And I'll go to a little more detail. So for medical care, the department coordinated and provided medical care in both congregate and non-congregate shelters, as well as in the community. We relied heavily on community partners who provided the direct services. The community response was awesome, and we're grateful for that. So we just helped provide some coordination and leadership among them to help ensure we are reaching as many people as could be reached. So again, it was a really collaborative effort, and want to highlight all the community partners that assisted. In addition, we did provide direct services where we reopened the Lahaina Comprehensive Health Center to provide direct services. Again, partnered with other nonprofits for delivery of care there. And the District Health Office was very active in supporting the re-entry zone services, providing support, behavioral health, and medical support to people as they returned to see their sites. For behavioral health care, we had a community behavioral health center in Wailuku. We expanded those hours and also established an additional site for a certified community behavioral health center in Lahaina. We partnered with other organizations to provide wellness checks within the non-congregate shelters and counseling. We were, worked with FEMA and SAMHSA. SAMHSA was a great partner. We received $680,000 for a crisis counseling program and additional funding from SAMHSA to expand that, and the $17 million grant from SAMHSA for the Supplemental Emergency Response Grant. So that's more for the longitudinal period, knowing that the impact will continue for quite some time, that folks will need mental health support. That surge grant is really intended to be community-based. So we've contracted with a resource center that will be subcontracting or has subcontracted with many different groups on Maui to provide services. The intent is for the community to determine, what they need and support them as well as we can. Also, we received the additional $150,000, particularly for children and adolescents. We look at a lot of data to help inform our decision-making. So these are just examples of some of the data we review. On the top left is emergency department visits for mental health related reasons. That you can see the red arrow was when the wildfire occurred. So you can see how there has been some increase in spikes thereafter. Hopefully, we're getting near pre-wildfire levels of emergency visits for mental health reasons. On the top right chart, the blue line are ER visits for suicidal ideation, and the yellow line for suicide attempts. According to the data that we have, there does seem to be some increase in suicidal ideation, but does not appear to be a significant increase in suicide attempts. We heard, reports of increased rates of death by suicide, which is certainly very concerning. So again, we looked at our data, and that's the bottom left of reported deaths by suicide. We thought maybe they're miscalculated. We looked at deaths by fatal drug poisoning, and we even looked at just total mortality rate during the same period compared to the previous 5 years, and have not seen an increase. But we remain very concerned. We're very active. The foot is on the gas to provide mental health supports on an ongoing basis. Okay, environmental health. So we conducted air and ash testing and established a network of real-time air monitors that the public can see, provided technical assistance support to their Department of Water Supply, and also we're very involved in debris removal, including working with the EPA on household hazardous waste, the Coast Guard on marine debris, and then the Army Corps of Engineers regarding cleanup of other solid waste. We're working with the county on their solid waste disposal plan with a temporary site that was determined to be Olowalu as they work to finalize the final site, but we work closely with the county on the debris disposition. And we're also working on supporting the infrastructure plans for wastewater treatment to support new housing. So this is what you can see online at fire.airnow.gov. The green dots are the locations of air monitors. You'll see some triangles. Those are these electron beta attenuation mass monitors. They're the regulatory air monitors. But we've distribute them both in Kula area as well as Lahaina area, particularly to understand during debris removal, might there be disturbance of ash that could pose a risk. So, with the Army Corps of Engineers, it's had a lot of experience. We trusted but wanted to verify. They did their own air monitoring, but we wanted to do it as well. And this is very transparent to the public. They can download an app and see this real time on their phone and get an alert if air quality were to change. But even when we heard, for example, at the Kula Town meetings, people who were watching the dust mitigation were very pleased with the performance of the Army Corps of Engineers in controlling the dust to make sure there wasn't any risk to people from the debris removal. So that's very reassuring as it now moves into the Lahaina area for the debris removal. Okay, we've spent about $1 million of general funds on wildfire response. About a third has been for travel, a third for services, and then a third was a mix, mostly equipment. Just to give you a ballpark, a lot of the work we've done has also been federally funded through those grants. Okay, the SOSRP incident. So this is a very significant incident for us, and it impacted us, I think the state hospital with the whole department. So a DOH employee was fatally injured on the state hospital grounds in November. In immediate response, we conducted a safety stand down of both the SOSRP and the state hospital to perform a comprehensive safety review that lasted about 4 days. Some measures were immediately implemented, such as reducing the number of residents in the SOSRP and increasing the staffing ratio. Community privileges, which is part of that program, were suspended. And then when they were restored, which they have been upon return, every resident gets a pat down, a wand search for metal, and a urine drug screen. Now, this plan was completed after the budget was submitted. So we're working to pursue a governor's message for additional funding for additional safety and security measures on the state hospital grounds. That's on the order of about $14 million. And that will be for facility repairs and enhancements, personnel and contracted services, provider rate increases, and community residential capacity. So the facility repairs and enhancements. So for example, more cameras on the grounds to be able to monitor that and repair cameras that we have, for example, increasing security personnel and their training, to reduce the hospital census, to have more capacity in the community so we can discharge patients who are ready to be discharged. The adult mental health providers have not had a rate increase in about 6 to 10 years. That is a rate study that is being planned. If we can increase their rates partially now, that will help until the rate study is completed and we can further increase their rates. We're also looking to increase the capacity for group homes in the community. So the more capacity we have to keep people stable and out of the hospital, and also to discharge folks from the hospital, will help reduce the census. Okay. So just from day-to-day operations, here are some other accomplishments. Fulfilled over 73,000 vital record requests. The vital records, we understand the impact these have on people, either trying to get their newborn covered with health insurance, or with the death of a loved one, settling their estate. So these have real impacts, and this is a place where we interact quite a bit with the public. So we've worked really hard, and I really appreciate the team's work. We've reduced the processing time by half, and we'll continue to work to make it better. There are several public education campaigns, including Sweet Lies. I was just walking around Ala Moana Mall over the weekend and saw the poster, Pasho Diabetes. So you may see some of those. Control Asthma and Be Fast for Stroke are some other public education campaigns. We successfully completed the transition of EMS from the state to the city county of Honolulu, and awarded 8 stipends for the KCC program. There were $5 million were appropriated to support cesspool conversion. We provided $20,000 grants, which basically were reimbursement for folks who had already converted their cesspools. And in a matter of about 3 days, all the funds were accounted for. There's a huge demand for that program. And I believe we've paid out about 3.7 million of it already. So that was a very desirable program. We formally launched a climate health program and created a new behavioral health dashboard. I'm proud of the work we were able to do, while also responding to the multitude of crises. But there's a lot we weren't able to do. When I asked my staff, because of our vacancies, how are we impacted? These are some of the responses. The number one response was morale. That the most significant impact of the vacancies has been on morale, that those are still here are working harder, and they're working harder. And, it's kind of that box of urgent and important. So the crises are urgent and important. So everything got prioritized to respond to those crises. But some of the more day-to-day work we just couldn't keep up with. So these are a list of some of the things. You have fewer people doing more work. Mistakes happen. There are delays in executing contracts or making payment. When staff are busy setting up all those air monitors, it takes away from time to issue clean air permits. So this is not a reflection of how hard staff are working. They are working hard. It's just that with the staff that we have, it's hard to keep up with everything. Okay. Across the department, we have a 26% vacancy rate. What are we doing to try and address the vacancy rate? So we have a public health infrastructure grant, and we're using that both to strengthen recruitment and retention. Recruitment activities include, we're starting to have outreach with DOE and with UH, trying to innovate some things where we're trying to hire some staff to be placed in DHERD to work specifically with some of the department's work. For retention, some of the best things we can do is increase the work environment. So those will be some of the activities under that grant. Some other things that we do If there's a delay in hiring into a civil service position and people are ready to start, we'll try and hire them either as an 89-day hire or into an exempt position while they're applying for a civil service position. So we're just trying to be creative with the tools we have available to bring people on as quickly as possible. We have some other ideas of some things we'd like to pilot to see how we can streamline some of this process. As I get later in this presentation, I will tell you the positions we're asking for. And I understand with, right now we have 3,276 appropriated positions, of which 866 are vacant. Okay, so that's the total for that 26%, 866 vacancies at the time I pulled the data. Of the 866 positions, 454 or 52% are new or vacant in just the past year. Of our vacancies, the Adult Mental Health Division, which includes both the community care and the state hospital, accounts for 1,200 positions, or more than a third of the department's total positions. Their vacancy rate is 30%, but they have 168 new positions thanks to you. So if you remove the new positions, their vacancy rate drops to 20%. Okay? With all of these vacancies, right, it's difficult for me to come here and say I need new positions without accounting for these, that I can't find a vacant position. When I went through the exercise with the staff to say, you got to find positions to trade off, just that, it negatively impacts morale. They have plans for positions get caught up in other activities. And even with 866 vacancies, I'm telling you, it's difficult to find positions to trade off. But so trying to balance my support of what they're trying to do and my responsibility to you, we are prepared to offer trade-off positions. We have identified trade-off positions if that's necessary. As we're looking at how can we work differently, we're never going to have the entire workforce we want. We're not going to fill all of our vacancies, but I know we're going to fill some. I just don't know which ones. So I know there will be vacancy savings. And I'm wondering if there's a way to for you to keep the vacancy savings now while we can retain the flexibility to move the funds for the salary of the positions we're able to fill. So we can reduce the funded headcount rather than just trading off positions or removing positions for vacancy savings. Maybe there's a way to think a little differently about how we can both realize vacancy savings and preserve the flexibility for where we can fill positions. Just trying to think through that. Okay, telework. I understand telework is an area of interest. The Department of Health has adapted the statewide telework guidance. What we've done is we only allow a maximum of 3 days per week, except for a reasonable accommodation. We can go up to 5 days a week. When we rolled this out, we had an initial approval period of 6 months. Now it's a 12-month telework agreement period. And any new or renewal of a telework agreement requires that there's a current performance evaluation. So we want to ensure that we are having accountability for folks who are teleworking. We only have about less than 10% of our staff who actually have a telework agreement. And you can see the distribution really kind of between 2 and 3 days of telework. Most of those employees on telework are actually from one particular division, our child and adolescent mental health division, where 95% of their staff telework. And that's because their work is in the field. So for them to go directly to the homes where they're providing services has been more efficient for them. Because they document an electronic health record, we're able to see their work has not changed and hold them accountable. And what's also interesting is they have perhaps the lowest vacancy rate. So there seems to be some association, at least in this case, of telework perhaps being a tool for recruitment and retention. But we hope we're finding a right balance, although we might tend to be a little more restrictive with telework at this time. Okay, moving to our budget request. We are requesting an additional $58 million in general funds and a net of 13 new FTEs, of which 9 are generally funded. Of the 58 million, about 50 million is for mental health related services. So of those mental health asks, 6.7 million is for the Evilay Resource Center, will be a crisis center. 20 million for the state hospital. That 20 million is for really inpatient contracted services, includes increased cost of medications, contracted nurses. At any one time, on average, about 50 nurses or 25% of the nursing staff are contracted nurses. 13 million is for additional contracted locum tenens staff, and those are mostly physicians and psychiatrists. And so this is the state hospital related ask. For the Child and Adolescent Mental Health Division, they did complete a rate study, and this 10.8 million is to increase provider rates based on that rate study. And we're also asking for an additional 4 positions to fully complement the Certified Community Behavioral Health Center on Maui. And as I previously mentioned, there's going to be a GM of about $14 million where we're still fine-tuning the ask. For the other 8 million-ish general funds we're asking, 5 million is to increase reimbursement for early intervention service providers, again, based on a completed rate study. 2.5 million for emergency medical services. That's based on a collective bargaining rate increases. And then some of the other positions, 2 are to help maintain Kalaupapa structures. 2 are for clean water management and enforcement as a result of the Supreme Court decision on injection wells. We're asking for a position for medical toxicologist. Following Red Hill and the toxicity of ash, we're just finding that this is a position, a resource we really need to have within the department as we anticipate future needs. And we're also asking for 4 additional non-generally funded positions. 2 of them are to support like a cannabis safety campaign to reduce cannabis use and misuse should recreational cannabis move forward. So that's 2 positions. 1 is a project specialist in family health services, and one's an epidemiologist in our alcohol and drug abuse division. Okay.
So that's the 4 non-A fund.
So it's a 4 non-A funded. Yeah.
What is the source of the funding?
So for those, either federally funded or special funds. So the 2 cannabis positions are specially funded, and the other 2 are federally funded. Okay. But great timing, because I'd like to accept your questions.
There was any questions? Oh, go ahead, Senator.
$5 million for grants for assessment. Do you have an idea of what communities that are for the grant?
So those are open for everybody in the state to apply. I don't know if anyone could speak to.
So the reason why I'm asking this question is, again, I'm gonna have to figure something out. Because nobody in my community is applying for it, even if they can, but they cannot even afford to convert.
Yeah.
We talked to you guys about this, and we're still moving forward. Sewer treatment plants is 5 miles away from the homes over there, and you guys still going into the direction of conversion. City blaming the state blaming the city. We need to come up with something, or we need to amend or abolish the bill that we gave to the city to convert in the next 2035, because they don't have a plan, they don't have administrative rules, but then they're gonna move forward in telling my community that they're gonna convert, but there's no fines if you don't. There's no way they're gonna be able to do them. I told them some of the houses are in the back and have sidewalks. Again, nobody at the city pay attention. They said my community no more sidewalks. every place in the state's got a sidewalk. They cannot afford none of that. So either we amend them because, Kelvin said I'm a legislator and I'm a lawmaker, and we should change the law. But he forget, he was here in 2017 making that law. So we gotta figure out with you guys and with my colleagues, because Ever Beach is not gonna be the scapegoat for the rest of the state. So either come up with a different plan, or we need to abolish that whole conversion. Because $5 million is the guys who can afford to apply, to get them converted. And you said that they gotta convert from septic tanks to sewer. A community again, before they make a bedroom for the the family member, they have to make conversion to septic. Are you telling them that $40,000 septic tank that they just put in maybe a few years ago, you're gonna have to abolish it and go sewer? See, I know we don't have the money, city don't have the money to finish our Hawai'i treatment.
No, but is that the case?
So that,
As
so,
long, they don't have to connect to the sewer line, do they? As long as they have the septic tank.
right, so there's a law that by 2050, right, all cesspools need a conversion. Certainly can, yeah, you're correct, right? So the cost of a septic tank, and that's just one option, can be $40,000 to $70,000, and people have to front that money because the grant was
What he's
reimbursement.
concerned about is that they convert and then they're being forced to connect to the sewer line.
So
Yes,
So is that true or not?
So there's various technologies. If it's an approved technology, they don't have to connect to the sewer. So if they put in a septic
So
system, they do not,
basically, it depends on what the technology of the septic tank.
if it's an approved system, they do not have to connect to the sewer system.
Okay, wait, Kathy,
So Senator Favela.
can you just state your name?
Kathy Ho, Deputy Director for Environmental Health. So the 2050, it's 2050 to convert cesspools. So by 2050, all cesspools have to be converted. It can be a connection to the county sewer system, or it can be an approved septic tank. So
But are you talking about if you have a current septic tank?
yeah,
So, because he's saying they already invested in the septic tank.
yeah, so this is the problem. See what you're telling me here, hopefully the city listening. That's not what they told my community. They told my community, whether you get septic or not, you have to connect to their system. So now you're telling me different.
No, yeah,
This is
it
the-
depends.
it might,
You know, the technology of the septic tank
Yeah.
sounds like.
right, and right. It depends on the technology.
But do you guys have like a PowerPoint for, like, that way, maybe somebody from the Department of Health can go to his neighborhood board and explain it?
We can.
Between the
That's
fire,
entirely in the-
between the
Sure.
fires and the Red Hill and all that, you
Everything else.
go to Ever Beach.
Oh, but,
Yes.
but the rector did come to one of my town hall meetings and gave some information, Chair. But what I'm trying to say is that our community, you can correct me if I'm wrong, Director. Our community is one of the only one of the few. There's a multitude. Ask them how much septic, cesspools we have on the island and how much they're gonna actually do. Because if Kapololo Valley don't have a treatment plant, they're not converting them. North Shore number one treatment plant, even though they definitely is contaminating the water, they're not converting. But then us will convert because we flat land,
No, but they have to convert from cesspool to septic tank, no matter what,
right,
no matter what. What you're talking about is having to convert twice.
right,
You got the septic tank, and then now you're being forced to
Right.
put. They're saying that's not the case unless the technology is not approved. So
Okay.
that's where I think you guys gotta provide some information as to which technologies are approved and which ones aren't, so that they don't have to spend the money twice.
Yes.
thank you, Chair.
So,
Go ahead. You had septic tank.
yeah,
Yeah, okay.
so can we get like one?
Yeah.
Because I mean, there's a lot that have converted to septic, but so what is the technology that is acceptable? Because upcountry Maui are dealing with the same thing. And then you look all the rural areas of Hana, Molokai, half of them are like, okay, we will convert, now we gotta upgrade. What is the technology that is acceptable? And then the different counties, because Honolulu's county gonna be separate from Maui County.
Well, do you have
Yeah,
a website or flyer that shows what they're talking about? Which are the accepted technologies and which ones are not?
Hi, good morning. Joanna Cito with the Environmental Management Division. We may have that on our website. I will have to go look. We do have a list of approved conversion processes. I don't know if it is on the website yet, but I will ask our program to put that there for the community members. The question about requiring conversion of septic systems, which have already been installed in areas where the county will be placing collection systems for their treatment systems. I believe that actually they do need to get connected, but I will double check with the county. It may be a city and county ordinance that requires that. So I will double check with Director Babcock to make sure whether or not that is true or not.
Okay, so if it sounds like if even though it's a county ordinance, if they introduce and pass state legislation that allows
That
whatever the
should not
standard for
be-
Department of Health, then that's it.
Correct.
So
Yeah.
maybe you guys might want to consider that something that supersedes that's reasonable.
Show me a short form.
No, you guys still got
No,
time.
the reason why it's concerning is because when he came out and the city came out, there is no evidence. The Clean Water Act said that a community has no threat to drinking and ocean water. But because of this law, forcing my community to go into that. Because we asked, and the Clean
So-
Water Brand said,
Yeah, so we
There
get,
is-
why don't you guys just work together on
okay,
some drafting something that maybe Kathy, you guys can help with.
because you know, something that's not smelling right now, you know what I mean?
So, going back to the $5 million, and again, I think the last time we had on grant program, I could just say all the rich people took them. And all the average Joes that lived on the ocean side, they just never have the upfront money to do them. So how you guys going try and strategize it or at least make it available for the other guys too? Because I mean, at the end of the day, what you gonna do if they don't convert?
Yeah, but that's the case, unfortunately, with lots of our programs, right? Even with solar,
Yeah,
and we have the tax credit, it's the guys with the upfront who can do it, and then the guys who can't do it upfront.
because my community, most of them is saying they cannot afford them. So what you gonna do?
Yeah, we wrestled with that. But it was this last session, it was a one-time program. And, we wrestled with who gets it. So, what we did was just to see if anybody would try to capture, is ready to, it was a reimbursement. And so one of the things we wrestled with is, do we give communities, homeowners the money up front and they don't convert, or do we ask for a reimbursement? And so if homeowners are able to, and what we did in this first project was we said it was a reimbursement. So if homeowners are able to give us the receipt that they were actually able to convert, we would reimburse them up to $20,000.
So Kathy, how about this? Because I understand what you're saying. The challenge is will you guys be able to say if a letter to approve the reimbursement so they can take that letter to the bank? Because then there's the commitment, so it forces them to convert. But it's because when they go to the bank and really, I think what you're saying is, oh, we're not keep trusting for use the money for the septic if we do them up front, which is understandable. But will Department of Health do the approval saying pending the loan, this is the reimbursement that you'll get that should be directed back to pay the loan of the bank?
Yeah, I think we could look into that. Certainly willing to work with you on coming up with a solution for rural communities.
Okay, thank you, Jeff.
Yeah. Okay, we'll go with this side.
Thank you. My concern has been with the nurses certification program. Chair Joy and I have been to many graduations, and we find that the most common complaints from the nurses graduating is that they have to come to Oahu for their one-day visit to get certified. And I think the concern we have is, how about sending someone to neighbor islands to do that, but I understand it also includes a test. So can someone explain to us, because we understand there's only one person in your office that does the certification program. It's very costly for these young nurse programs, the nurses that graduates, and they say it seems like, they want to come to Oahu as soon to be certified. But it depends if they have their resources to pay for the trip to come over.
No, I understand your concern. I'm not, there's the Certified Nurse Aid Program through Department of Human Services and licensing through GCCA. I'm not sure.
Chair Joy?
Yes,
What's it, who does the certification?
I know that
We were
sort of-
there's some certification.
Yeah, we were told that
We do for dietitians.
That's it.
And
it's-
med
I
techs.
thought there's some nurses.
Oh, it's.
So it is identify yourself.
Debbie Kim Morikawa, Deputy Director for Health Resources. And we don't have an OCA chief right now, and I don't believe anybody is here. But I know we do licensed dietitians, and I don't believe we certify our licensed med techs, but we,
So
License-
perhaps DCCA then?
yes,
Maybe we'll inquire.
we do not do
Okay.
nurses.
And we'll follow up on the med
Somebody
techs.
shaking his head in the back there, maybe he knows. Okay,
Okay.
thank you so much.
Okay, Senator Kim.
I wanted to talk about the vacancies. Just glancing through, it seems as though May 31, 2024 is the magic date, because it seems like all of your vacancies have the same date. So something magical will happen that you're gonna fill all these positions by 5/31/24.
Yes. I don't believe so.
So why do you guys put those dates when you're not gonna fill it all?
I suspect there's hope and there are ambitious dates that if the request to fill has been submitted, the hope of how long.
100 positions, hundreds
Yes.
at 5/31, and you can barely fill. Okay, let me just go on. So you have positions that have been vacant from 2008 for social service assistants 4. There's 2 positions. You have positions that have been open since 2013 in nurses and social services A3. It's 2015, 2014, and you all have the same date. So apparently every year you probably you're going to fill those positions by the date, and it never happens. So, these are really old positions. So that's been vacant for a long time,
Yes.
more than 10 years.
Yes.
So maybe it's not needed if you've gone without it for so long.
You're correct. There are 32 positions, or 4% of our total vacancies, that have been vacant since 2018 or earlier. So we looked closely at those 32 positions, as I've offered up positions for trade-offs. We looked into the oldest ones. Some of them, and I'm just reporting, they're reorganizations that have not been completed. There are other reasons why the programs felt they still needed those positions. But I understand your concern. We're looking at them.
Can you also provide to the committee how many positions you will not be able to fill due to the salary vacancies, money being used to pay for higher salaries, because those are reoccurring costs. So if you've taken money from vacancy to pay, and I notice you have your list of positions that are being paid higher than what the stated amount is. So how many of those positions literally you're not going to be able to fill because you've already taken the money and committed it to another position?
So looking at our vacancies and the ones that are paid above kind of their amount. So
That's
when I did that list,
Table 21.
table 21, the top ones are the physicians and the psychiatrists that are being paid above kind of the position salary. So when I sort it I just did this on the side because I was looking at that same question, is what's the percentage above the base that their actual salary is? And I did it both by percent and by dollar amount. And we have psychiatrists who are paid $100,000 to $180,000 above their base salary. And some of that is what we have to pay to be able to get psychiatrists. We also have, positions, a lot of nursing positions that when they're vacant, their base salary doesn't get the adjustment that the pay scale would increases. So then when we finally fill that position, the amount we have for the position will be less than what we need to pay them just on the pay scale. So that there's some catch up that needs to occur. But there also are people that are getting paid above.
Right.
So it's, we try to be very specific when we look at the budget. And for a variety of reasons, I think it's, that's where it just becomes kind of an average, and we're in a cycle of where we're not really trued up on what are our actual salary costs, relative. So there's some vacancy savings. Yes, we do need for different kinds of reasons. Some we might consider more justifiable than others. How much money do we need? Well, we know that we have a lot of vacancies. We have a lot of vacancy
Well,
savings.
maybe something is wrong with the way we are budgeting and the way we're doing this budget, because if in fact we have all these positions, it's disingenuous to say that we have all this money in all these positions when in fact, that there's a bunch of positions you will never fill. And you just need it on the book so that you can pay these other ones. I mean, it's just, it boggles my mind that how we operate government in that manner, because we're really not being true to the taxpayers so they can really see exactly where the money's going. We have no way, this body has no way of holding you accountable for all those salary savings, vacancy savings, because we have no idea where all that money is going. Some may be going to pay higher positions, which we didn't approve. Some of it is going for current expenses. Some of it is going for we don't know what. And then you have the word slush fund that comes up to say that, these agencies and departments are using all these monies for whatever they deem it is important, and we didn't budget it for them.
No, I understand and agree. I mean, I'd be very interested to seeing how we could, work to see.
Well, positions need to be reclassified or upped as far as pay wise, if that's what it is. To steal from Peter to pay Paul and not have it on the record, to me, is not the way to run a budget and government, right?
I agree.
So what keeps you folks from doing that? Just the paperwork?
Sounds like it was an arm wrestle between him and the branch chief or the division head on some of these things.
So some of those are just that, I mean, there's, removing a position and then chasing it to reestablish it. It's a lot of administrative work. If you're just trying to, let's say, unfund
So
a position.
maybe that's the problem then. The fact that there's so much administrative work to reestablish it. Because if that seems to be a common statement by many departments. And so that goes back to DHERD having to streamline the process so that we can hire, because you hire it takes so long to hire somebody. And then when you hire them, it still takes so long to process it. Then they found another job already.
Yeah, and
So
then
that's where DHERD has to help streamline the process.
yeah, and then to increase the salary so that we can keep these
Yeah.
people in
Yeah.
the positions, need to have a simpler way of doing it, and then be able to put it on the book so we know what the true cost is instead of this false cost.
Yeah.
By carrying all these vacant positions just for the fact that you want to fund these other positions.
So when you increase the salaries, do you have a schedule, or, I mean, are you just saying, okay, what will you come work for us for? And then you
So
increase it? Is there
most of it is collective
standard?
bargaining, though,
A lot of
right?
it's collective
And
bargaining.
then some
the ones that psychiatrists? for
So those are, most of those are exempt positions.
example? So the other positions.
Yeah. But even the civil service, there's some leeway to go higher, right?
Within a range.
Yeah.
Yes.
So I think.
But
yeah,
those are
you can-
steps though.
Yeah,
Those
those
are
are-
steps. Those are set in law, but the exempted positions.
But Chair, it seems like we're continuing to hear DHERT's problem. We've been dealing with this since I've been here and, no different than the hiring we have in DLNR with our engineers and
Yeah.
everything else. But
Yeah.
maybe you should just create a bill and put a
So
time
We
schedule.
have quite a bill.
Put a
There's
time-
quite a bit of
good.
DHERD bills, I think, this session.
Great, put a time schedule. So our agencies and, that they can do their work and hire the people
Okay.
in a good time schedule.
Senator Kidani.
Thank you. I don't disagree with some of the comments from my colleagues, and I think a good example is on table 11 of your report. We have 2 special ed teachers, which I didn't know was within HHS rather than DOE, but their salaries start at almost a $3,000 annual difference.
No.
It's page 66 and page
Okay.
52.
On ours or on theirs?
Recess. Okay, calling back to order, Senator Lee.
Well, thanks. While we wait to sort out some of the issues here, I just had one question. It relates to food safety. For a lot of small businesses that are opening up restaurants and shops and things like that, it's really hard to make ends meet sometimes, and especially get going with some of the challenges that we face in Hawaii. But there's a really great example downstairs right now in the snack shop in the Capitol for all those, not only in this committee hearing, but those listening in the building, that has great muffins and all kinds of hot food and new stuff run by a young woman who's trying to get that thing going. It's a great example of how to do food safety right. Are there other ways we can export this model and make sure that other businesses can do as well as the excellent food being served right here in the Capitol now? Oh,
Did anyone go downstairs?
Yeah. I saw them on Sunday.
Yeah.
I think that's the vacancies.
I'll take the answer offline. Thank you. Thank you, Chair.
Okay, let's go back to the vacancy report with the 2 instructors. Senator Kidani.
Yes, so they're both special ed teachers, been vacant since late 2022. And you show a fill date of 5/1/24. So how are you planning to accomplish this? Being it's been vacant so long. So I guess the other part of my question is, have you guys tried offering maybe higher bonuses? And I don't know if you can use that. That's the thing the budget chair is going to have to answer. With all the vacancies you have, you're not filling any positions. So to be able to fill those positions, what other things are you guys trying?
Matt, you can speak specifically to those positions.
Hi, Matthew Shim. I'm Chief of the Family Health Services Division. The special ed teachers that you're referring to are part of our IDA Part C. That's the Individuals with Disability Act Part C, which is children birth through 3 for our early intervention. So part of the services that are provided to families with children with developmental delays, some of that includes special education teachers. That's what those positions are. And just like DOE, we are recruiting for the same pool of people, and it's very difficult. And the state pay scale is not competitive with the private sector. So teachers often get different jobs other than teachers. So it's very difficult. We advertise, we recruit, we interview, and sometimes they already have another job.
So these teachers are all under HSTA. It's all the same group of teachers.
No, they're not
No.
DOE. They're not DOE. They're
Okay.
they're DOH.
You go into the-
HGA.
Yeah, HGEA.
But they're teachers that have to have certain qualifications. But they're not DOE teachers.
Correct.
So the qualifications are different than DO.
They still have the license or credentials as a special ed teacher, but they're not teaching in the DOE system. They're teaching
No, I
specific.
understand that.
Yeah.
I'm just saying, so, but do you guys have to go through HSTA to hire? No.
No, we go
Okay,
through
So my next
HDEA.
question is if it's, I don't know how long, it's been over a year since they've been vacant. And I would expect that this is very important for these children that need the teachers. So what else have you guys been trying to hire?
Well,
Like
we've
you
done,
said, the stiff competition, you have a difference already in these two positions, same positions, DOH teacher 3, but they're over like $3,000 apart in salary. I don't understand that.
So
Then
this-
they have a new position higher up there, they just got, and that's been vacant, but it's new, and that's been paid a different amount as well.
So I think it
So,
goes back to making sure that you guys are working with DHERD. I don't know. I just don't understand the discrepancy.
so on the vacancy report, the salary that's shown is the salary of the last person the last incumbent. So if the incumbent was hired or left the position in 2017, that step in salary is based on the HGEA bargaining unit 13 pay for that particular series step. The newer position is based on the newest or most current HGA collective bargaining. So because it's a new position, we have to give the estimated budget for that position based on the current salary.
Why would you have a new position when you can't even fill the other two positions?
There's different programs within the same early intervention services.
Yeah, but you can't fill the other two. What makes you think you're gonna fill that one? You created a new position.
We've also taken some of these positions and re-described them into social workers to use the position counts to provide other services.
The new one says special ed teacher 3, and the other two that's vacant is special ed 3. So if you changed it, it's certainly not showing up.
Okay, well, seems like you guys got.
We'll have to-
reconcile, yeah.
Yes, I can answer your specific question by going to the program, and I'll have to get back to both you.
The concern is you have vacancies, you create a new position for the same one you have vacancies, then you take the money from the old ones and you put it somewhere else. To me, that's not, I'm not just saying this with this, but I'm saying that's what seems to be happening. Create a new position and then you take the money from the old one. It's like you're just moving the shells around.
Yeah, these positions are paid for by our IDA Part C federal grant. So,
So you do it with federal monies and, I mean, it doesn't matter where the monies are coming from, but that matter is,
yeah, so we don't use vacancy savings from our federal grants to fund other
But
higher salaries for other people.
but you're
It's all
still creating a
budgeted.
new position for positions you cannot even hire. We have the people to fill.
And that's the grant requirements for our program requires a specific number of special education teachers for children 0 to 3. So we're federally mandated to make sure we have those positions to provide services for the
Somebody
children.
cannot fill.
We try to fill them.
Right. I understand.
Well, the
Okay,
cannot
I'm
fill,
not gonna be
the cannot fill is we are trying to fill, and I think all the agencies have been coming to you, telling you how difficult it is to hire
but
all
I
positions.
guess the point I'm trying to get to is that these were two different teachers. They're in the same level. They were at different pay,
Yes,
but your budgeted amount is at the pay that both of these teachers left at. So
the budget tables won't be upgraded or updated until the position is actually filled.
but if you're budgeting for 71,000 in one case and 60,600 in the other case.
We have a correction that we have to do with our ASO folks to correct the budget tables. It's part of our normal administration. So we create a budget for like the federal grant here for the IDA Part C. We create the budget at the current salary. even though the budget table has the salary at say $68,000, but we know that the current recruiting is for $76,000. Our budget is prepared for at the $76,000 level, and then we create a BJ2 table update to update that position to the current. So
You're
our
just
budget
saying that
reflects-
It's not, two positions are gonna come in new and you have two different levels of
Well,
salary
and-
you're offering.
And the new position is at 51.
Yeah, I'm just very confused.
Yeah, so
Yeah,
the,
it almost seems like your process is a little backwards. Like if you're presenting it to us, it should just be whatever the budgeted amount is.
And that's what's here on
No,
the,
but-
this is actually budgeted in the state budget, for our budget
Yeah, but
plan.
you're saying that when you hire them, they'll get a higher salary.
Oh.
Yeah.
You'll get the new salary.
The new
So why
salary,
aren't you just budgeting the new salary?
because we can't until the position is filled. I don't know.
Because
I
then,
don't know the
but
reasons for
then you may
that.
not have enough money for it then.
I agree, the money,
Why? You should budget it for what you're gonna end up paying.
so, but then the new position is at 51, so are you gonna pay that new position 70?
Yeah, again, it depends on, I have to check the actual positions, but these may actually be position totals for folks who left the positions.
Well,
I-
that's
I'm
what it-
Okay,
that's what it
that's fine. Yeah,
says.
we're going in circles, but that's fine. I think when you present a budget, it should be what you're going to pay the next person when they're hired.
Exactly.
Because then
Okay. You're
if
asking
if
for
you're
money.
coming in and you show us all the old salaries and you hire, then now you're short.
That's why you're hiring above.
So that's something that we probably should, from the WAM side, you guys gotta look at and
Okay,
change that.
well, if I was doing this budget, and I'm not saying it's an easy job, I would have taken the two teacher salaries, 77 and 68, whatever it was, and divided by two and plug that number in, because you're plugging the same number in. If two people came in at the same time that wanted the position, you're gonna offer 171 and the other one 68,000.
Well,
I'd say, no, that's okay, because you're not offering me the same as,
No, but,
that's what I'm trying to get at.
but the new position is at 51, so that's even worse. Why would somebody come in at 51 when there's two existing positions that?
but that's not how they post it. So what you see in the BJ table is different than what's on their website posting for the job. That's what I'm saying, that salary that you're posting should be in the BJ table.
But Chair, this may be something that all the departments do, how they do budgets, and I'm just not saying you guys, so I think we probably need to just ask. I mean,
Yeah, we can say what the advertised amount is. We can say that, because then that way we can see a better idea.
because that's why you're always hiring above.
Well, and
what
then
the
that's why
budgeted
you end up
amount is.
stealing
Yeah,
from Peter to pay Paul,
doesn't make
because you haven't really budgeted the salary that you're advertising.
Because Paul gonna pay Peter.
Yes.
and you can't
the-
really
the-
recruit if you don't.
Right, then we
salary.
risk the problem though, then if we if we don't fill the positions or they're not full for a full year, right? Then now you have all this additional funding. So right, so from a budget perspective, if you're appropriating funds, then for those now those vacant positions at the higher salaries that we're asking money for that are vacant, it will increase our vacancy savings. So we're trying to figure out the kind of, and we can work through this on what's the best way to do this to fairly represent our projected costs, but also recognize we're not going to fill all these positions for a full 12 months.
Well, you may feel it because the salary is much higher than what
No,
you're
but it doesn't matter, because the public they don't
No.
advertise these salaries. This is just their budgeted amount. Then they're gonna, when they budget it, when they actually go out for recruitment and you go online and you look up the salary, it's probably gonna be different than this. So we're arguing over something that's not really real. This is just their budgeted amount.
Are they allowed to offer hiring bonuses?
No, it depends.
We don't do hiring bonuses. Typically, positions are posted with a range, depending on that individual's particular qualifications, they may land at a different step. So typically what's posted is a range.
Yeah, including those two teachers. So one
Yeah.
teacher might have 2 years experience, one might have 8. So that's where
We
the
might have-
salary differential could make a difference.
Hmm.
If, you guys are assuming that they have the same background,
Right.
same experience, same education,
Wait,
and
wait,
that's not necessarily the
I guess that's
case.
where you put them in the job description. If you get 8 years or whatever.
Yeah, but
because
that
you
goes
get
back to a
paid.
DHERD problem.
Yeah.
Because DHERD is giving them the limitation as to how they can post. That DHERD has to review the job description. DHERD has to review this. DHERD has to, it's almost micromanaging the process.
And anyway, we can go on straight line instead of in circles now.
So, okay, next.
Okay, so, I
Oh, yeah. Do you?
Yeah, you want me to ask
Go ahead.
questions? Okay, well, one fairly easy, I think, we're in the 21st century, right? So which means you see everyone with laptops. Do you have anybody in charge of updating your website? Because there are portions of your websites that is like super old. Like when we went to Molokai, your resource center stuff, your resource list was antiquated.
Well, the cesspool list, technology list is,
It's antiquated. But if we want people to be able to help themselves, do you have anything in your budget to require at least your department heads to be on top of it to update your website, at least their portion?
the divisions.
Yep. So we have a new communications director. We understand the need to maintain our website and keep it current.
And they're here.
And is that in your budget? Because it seems to me,
They're watching.
Yes. We do not, like other departments that have an exempt PIO, we do not have one. And that's been a limitation. We are actually using a grant to fund our communications director. And the civil service position we have is an administrative assistant 6, which, because it's a standard position, no one knows that's being used for the communications director.
we got a bill because you signed your budget.
We're not asking this year, but we would at some point like to have, like other departments, an exempt basically PIO. That aside, we are working to upgrade our
I
website.
thought like Brooks Bear at one point. What's your guys?
So Brooks was in an exempt position, a grant funded position. Brooks has left. We're using a different grant to hire our communications director that we have, who's newly started. We are reviewing our administrative rights as far as who in what divisions has access to upgrade their content. And we're actively in the process of reviewing the website and ensuring it's current.
So when?
It is in process. So
So you don't know when.
No,
when
can
each
you
of
guys
these-
develop a plan by the time the Senate gets the budget?
As to updates, because it's also regarding transparency, right? If people are thinking that you guys are hiding behind things when you folks don't put on the website, which everyone has access to, what it is you folks are doing and what your requests are. And like cesspool conversions, like people in remote areas who can't go to a department that we've seen in like Molokai, and we pull down your resource list and 90% of what you claim to have resources are non-existent. I know you just got appointed, but we need to be in the 21st century.
I agree that information needs to be accurate. I commit that we will do so. And if you find information that's not current or missing, if you could please let me know, then I can follow up on it, but we will work within our divisions and ask them to do that. Absolutely.
Okay, but you also need to have a schedule to make sure and maybe assign each of your department heads to at least delegate to somebody to make sure that the content, because when people come to us and they ask us for things like nursing certification and the like, we would like to be able to just point to a website instead of having to make the phone call because of your high vacancy rate. We won't even be able to maybe have a human person to answer our phones. All right, so, okay, have a schedule, please.
Yes.
Okay.
And not only the content, but how it's presented, it really should be public facing, so that anybody can read through it. I know the Office of Healthcare Assurance has a they have a web page, but if you go through it, when people want to know where can I put my mom or dad, they really should need to see the inspections on site, on the website, but it's really hard to get through this whole bunch of data, rather than what I need to know is it, you know,
Yeah.
meeting regulations or not. Simple information.
Maybe
Yeah, I
need
think
to
you,
work
I
with
think you
Murdoch.
got it. I think you got
Okay, I
it.
got a whole bunch.
Okay, Senator
So-
Chikoi.
Thank you, Chair. So I just want to follow on what Chair Buenaventura said. You know, you get all these vacancy positions, you don't even have one position proposed for Molokai. I mean, the skyrocketed suicides, the mental health resources. You know, I was grateful that, you know, Chair came to Molokai and did the suicide prevention. But we were literally given one flyer and I followed up with the office, came in with the corrections. Till today, there's nothing. People have no place to go, nobody to talk to. You know, of course, we put a bill in because the lack of resources. We get stuff like burning going on next to a residential area. That of course is like, oh, we're gonna send somebody to Molokai. Or, you know, we cannot get a flight today because the flight got canceled. I mean, why not put on position since you get so many there that can't be filled? I mean, I cannot send them to the website. I'm trying to like do recon and then we get public nursing trying to answer some of these questions. So, I mean, I'm trying to be nice, but when you get people that need a place to go to and like I said, the website, if you're not going to give them body there, then at least update the website. And the fact that, you know, we're working on it, it's not cutting it anymore. So how do you guys help us, help our constituents that are lacking services? And I can tell you within the past several months, the suicide rate on Molokai has continuously climbed. It probably is the highest per capita today. And I have no place to send them to go. Neither do you guys send people to Molokai or even our other rural areas. I mean, we can probably draft as many bills to try and help you guys. But what does that get us when we still see the decline of the services that we depend on the Department of Health to provide?
And to follow up on that, we showed, you know, we showed Marian Suji what was on the website, the resource list, and whoever, it wasn't Marian Suji, whoever was the Molokai Department of Health representative. We told her that this needs to be updated because when we made the phone calls and we showed it to the resource providers there in Molokai,
Yeah.
and you know, for
Get
a small island on the middle of a work week on a Monday, on the middle of a work day, a lot of people showed up. I mean, like talking about 50 people showed up.
And they were disappointed on the responses that were given.
Okay, and that was over a month ago.
Yeah.
And we still to this
Still
day
never get
don't have an
nothing.
updated.
Yeah. Mrs.
Okay.
Linker actually did the update from public nursing to give to the department. We sent it in and we haven't gotten nothing.
Okay, what do you want them to respond to?
I wanted to respond to the updated programs that is available and what they're lacking that is needed, more so on body there.
Okay, Marian.
And resources, is there any request?
So Marian Suji, Deputy Director for Behavioral Health, and we have 4 positions that we're requesting for the Maui CCBHC. So services are being provided through Maui because Maui, Lanai, and Molokai are all considered part of the Maui branch.
So I get that, but Maui is still separated between Molokai and Lanai. Molokai and Lanai are struggling because there's not a physical body there. And even if you got to bring them over, again, we challenge with the airlines. So
Yes.
you guys
So-
got to position them on those 2 islands. You guys can't just be, oh, we're going to leave them on
So-
Maui.
So some of the clinicians we're having a hard time recruiting clinicians for Molokai and Lanai. as well as, throughout the state. What we do have on Molokai right now is part of the crisis counseling program that was originally funded by FEMA and is now being funded by SAMHSA. It's not considered clinical, but it's more talk story, folks that are trained in psychological first aid so that they can identify folks who need further assistance and then reach out and provide that connection with the right clinician.
So when were you guys gonna let my office know that? And then how has that been portrayed or notifying the community about that position?
I will definitely follow up on that.
So did it take us to have this conversation now for you guys to follow up? And how long ago did you know about it? Because we contacted you.
We have been providing this service. I will follow up and make sure that there is more media and publication of the services that are available.
That would be helpful. Thank you.
Who's your guys' government legislative person or?
Lauren.
No, so maybe just follow up because it sounds like if they're so busy, they need somebody to make sure that there's constant communication between the deputies and the Senate, the committee members. Because you're asking not just for all the things that she's talking about. You want to have up to date. Yeah.
I mean,
Okay.
that's what they
So
like.
you guys can just.
For Maui, I
It's
mean,
Senator
that's what
Favela.
they're like.
Maybe you're not gonna have the answer right now, but I sent you guys a letter on PVT, the rupturing of their liner and the condition of PVT. I know you guys said you guys have ongoing issues with them, but you guys ever went out there that the mountain, they're gonna have to name that mountain something because the mountain in the back that has a name, it's smaller than the mountain in front of PVT. PVT is still continuing to be open, even though we're having all the health issues that we're having out there for generations and the rupture of the lining. When the lining was put in, I had asked when you guys had approved the lining and how outdated the lining, because the lining only lasts so many years. But that PVT was supposed to move across the street because they already want to fulfill their contamination of that land. So they was going to contaminate another land across the street. But I never got any answer on the lining of PVT.
I apologize if you didn't, again, Kathy Ho, for Deputy Director for Environmental Health. I apologize if you didn't get a answer. I believe my staff went out and did an inspection. I will follow up and get you the response.
Okay.
Thank you.
Their solid waste permit wasn't renewed. So how are they operating at PVT? Operating at the landfill, you need a solid waste permit, and I know that the permit had been expired and not renewed, so can you guys let me know that?
I will. Yeah.
Thank you, Chair.
Okay, we have a question.
Okay, Kaneohe State Hospital. You had a $14 million ask, but that was before the death, I believe. Are you making supplemental ask? And how do you folks?
The 14 million is going to be a GM, so that's not in their
Yeah,
budget.
okay, so that's not in there, but what I want to know is how does that coordinate? There is another bill where, and I don't know if it's a Department of Health bill. I apologize. I don't know whether that's a PSM, but it was seeking mental health treatment centers in public safety in the correctional facilities itself. Are you aware of that and how do we coordinate? Because Kaneohe State Mental Hospital shouldn't only be forensic, right? My feeling is there should be room there for services for families who have schizophrenic kids so that we don't have another Takamine incident where they attack their own family members and kill them. If we have these mental health treatment centers in the correctional facilities, would that in any way help you folks at least deal with the public safety issue.
That
Because then
would-
you have ACOs who can handle violence.
That,
mentally
that
ill.
would definitely help, Senator. I mean, we talk about the continuum, and right now at the state hospital, we have folks who are mentally ill. And because of that mental illness, commit crimes. And then on the other side of the continuum, you have folks who are criminal, but also have some mental illness. And right now, because the hospital is the only place to get any kind of treatment, we end up with everybody at the hospital and we're overcrowded. And it's therapeutically not as effective because you have folks that are more of the criminogenic side,
Mhm.
kind of undermining some of the treatment. So having something within public safety, we would definitely support.
Or why not just have some delineation between the two in the current facility?
The treatment right now is all forensic.
Even though
And-
with the increase of, so even with the increase in size, it's maxed out.
It actually did not increase in size.
Well, now you
So-
can see it from afar. Before you couldn't really notice it. But-
Right. And so Senator is absolutely correct.
But is
I mean, we
public
need
safety ready
room.
to do that? I mean, I don't,
They've been talking about it
Mhm.
and they've been working on plans to do more of that corrections and rehabilitation.
with their existing facilities.
They're talking about a new facility. Well,
Well, I'm also thinking that maybe we should, another option is to look at the current hospital in Kaneohe and see if we should be building similar facilities on the neighbor islands where where it warrants, where it justifies because the population is large enough to justify a facility like that.
But I think that Senator is correct. We do need room for civil commits for families who have no place else to turn. And folks that haven't necessarily committed a crime.
Yeah, because I'm hearing
But
about.
right now, you only
the
have the one
community.
facility, right?
Yes,
So what?
Don't
It-
know.
I mean, there's.
we have the
different-
one facility and then we contract out bids.
But is it time to look at where you might need to justify additional facilities?
What is the state hospital? But you have other buildings on the grounds, right? So, yeah, so how are you using that space and what can you do? I know at one point there were supposed to be stabilization beds and then so you could actually have a graduated kind of.
Correct.
No, it doesn't sound, okay, you know what then? It doesn't sound like there's a real concrete plan then. As unfortunately that population increases.
Has grown.
So that's why, is the plan gonna be to partner with public safety? Is the plan what I'm talking about, where you look at additional, is the plan where are we headed with all this?
I think with public
No,
safety,
I think you guys should go back and come up with a real plan. Because what's your projection?
Yeah, because we really don't want,
We're reacting now.
yeah, we're
So
at,
what,
yeah.
what's your projection for the numbers? And then do the existing facilities able to, and the staffing, is it able to accommodate those projections?
the projections are that we will continue to grow.
No, so
Right.
yeah, I just asked you,
Right,
are
no,
the existing
yeah.
facilities and staffing
What was the
are
plan?
able to accommodate that growth?
So.
And
in
what-
Yes or
partner-
no? No, yeah.
No,
Okay, so then what's your
Projection.
plan so that the state is more proactive
So
instead of
we-
reactive?
we have a number of requests for CIP so that we can continue to utilize the Goonsburg building, which was originally
So
slated.
that's
for
maxed out at
demolition.
what? Is it maxed out now? In a couple of years,
It-
it'll be maxed out?
It is, and we had already identified that as being demolished and a rebuild. It doesn't need to be another rebuild like the facility that we just opened up, but we do need another facility. We also have Bishop. It's a building that's
So
closer
yeah, but
to,
what's typical when we're trying to do some kind of forecasting or projections? The next 15 years, and then we start to plan for facilities and staffing for the next 15 years? Because it sounds like you're talking short term, like even just couple years.
so there was a plan that was for the longer term, 15 years. And I think that what has been happening is even within 5 years, things have changed so rapidly that we have not been able to keep up.
Okay, so can you update that plan and present it to us?
We are planning that with DAGs right now.
But it's not just the DAGs, it's going back to,
The projections
Mhm.
and then what are
Staffing,
you staffing
programming.
in the building requirements.
because I'm not sure how people feel about merging some of these patients in with the public safety system. With corrections.
Chair, and to add to just as what you're saying, for the neighbor islands, as an example, for Big Island, we probably don't need a big office similarly to your state office here, but do some satellite offices. So satellite communities, because as an example, right now I can tell you, we can use the old Matayoshi Hospital, that, you know, is abandoned, and there's facilities that maybe you can do, you know, a satellite program. And with the disconnection that the chair just mentioned, perhaps maybe you don't need areas that would be a combination with public safety.
Yeah. Okay, you know what, then I think that there's some confusion in what we're trying to say there. Because like you said, there's two spectrums. There's more criminally bent and more mental
Mentally.
health issues, right? So what I'm talking about is a combination of the two. So when you have the criminal bent, those should probably be partnered with corrections. That
Right.
makes sense. What I'm talking about now, the scale of the other population has increased on especially the neighbor island. I can't imagine that population now being going into public safety corrections.
No,
No,
but
but then I'm saying when the scale's too big and you have no facilities on the neighbor island, and you're saying Oahu is already filled, so now what are we doing? But there's no plan for that population as it continues to grow outside of the correction system, which really should be some mental health facility.
Chair, but maybe we should be asking,
So
has
the
there
plan-
been studies in other areas on the mainland, wherever, of, do we separate them? How do we do, what kind of facility we need? And do you have any of that information? On what?
so right now, the plan for the neighbor islands is to stand up certified community mental health
So that's
centers, the
partnering-
CCBHC.
That means you're gonna partner with someone else, or the state is gonna be the lead,
The state will be the lead.
state facilities.
Yes, and last year we received full funding for the positions for the CCBHC on Big Island.
It's outpatient.
It's all outpatient.
I know, but what she's talking about is like the Takamine situation.
Yeah.
But we're also asking for some stabilization beds, some group homes, because those are community-based treatment that we could use on the neighbor islands.
But is this what is the current trend at how we do this?
Yes,
That's what I'm asking.
Yes.
Yeah, so I think that's part of what we don't know.
So in that situation that she talked about, that unfortunately in court, where would that patient have been if we had the facilities? A community-based one?
no, I think that there would have been a community-based program to go to for any kind of crisis, for urgency.
But that's not
and-
residential though.
No, it's
So
not
then
residential.
they're still,
So
it still would have,
depending
it could
upon
have
the
happened.
acuity of
Yeah.
that person, they may have had to come here.
Well, that's, so at what point,
Right.
there's enough of a population to justify the residential on the neighbor island?
We can take a look at those numbers for neighbor.
Well, if
islands.
not, we're gonna.
Right now, yeah,
I mean, you don't want this situation to happen again.
totally agree. Right now, we're maxed out pretty much with all
Yeah, I
of the
guess
first.
that's why I
It's
asked
like-
the
it's like-
question.
It's like Department of Ag with the biosecurity. We're asking, okay, here's the problem, what's the plan? They don't really give us a plan. So we see that this is coming. This is like a train wreck coming. We can see, okay, this is going to be a train wreck. What can we do to avoid the train wreck?
So some of the things we're doing, right, is a continuum of care. And the more we can invest in the outpatient, right, sustaining folks, then, the less people will be unstable and need kind of that more institutionalized care. So some of the things we're working on are these community behavioral health centers. And that's for kind of outpatient, ongoing care. Okay. And then this is on top of the community mental health centers we already have. Then for that next level, people who may have a crisis is, can we stabilize them? And then return them back to kind of more intensive outpatient. So those are crisis centers, of which we're preparing to implement the first one, which is the Evil Aid Resource Center. And then if in crisis, they can't be stabilized, then they need a longer period of stabilization. So that's the thing is also what's
No, I
nice
think
with,
I think everybody gets the theory. What we don't understand is, when are you going to start asking for the money for plan and design of those facilities?
so
So
Like,
we,
well, like she mentioned to me, the Kona.
That
The corner-
stabilization debts, how did that, I mean, you folks ended up doing basically a nonprofit, right?
Right. correct.
Instead of having it part of, Department of Health.
Oh, and we know in Kona we have room. We have that big empty building next to the hospital that DAGS has left vacant forever.
And
And that easily could have been something that could have went to
yeah, in
supposed to something
looking at that building, it would have.
used for mental health. It could have been used for mental health.
It would have required quite a bit of money, an infusion of money
Okay,
to,
so then what? You want more
to be
people?
able to
You
use
want-
it.
I know.
So-
What's the option then,
So,
if you don't do it?
so I,
More, you don't want more incidents like that.
correct.
We need a plan. So this is the projection. This is what we
Mhm.
need. We don't have the money now, but at least we're working towards something instead of saying we don't have the money, so we're not going to do anything. That's the problem. So if you have the behavioral crisis centers, where are they? Where are they located? What's the staffing? How is the continuum of care going to be moving them into higher levels of care? But what is that big picture, that plan for helping those in need in the community and institutions?
Okay, sounds like this is a longer info briefing and subject matter, but there has to be something a little more concrete, especially after we see a trend. I mean, you see it on the news, a trend of these kinds of incidents. Unfortunately,
How are you
So-
folks handling the homeless who has mental issues?
That's supposed to be a stigma.
So some of them come to us. We have our community mental health centers, but many of those folks also receive their services through Medicaid. 80% of those with SMI are receiving their services through Medicaid, and we're providing the services for about 20%.
Are you coordinating the services for mental health, substance abuse that's occurring in the community so that these providers aren't just, doing their own thing when the homeless are dropped off at a site? They can't just close the door on them. Are you doing anything to be more proactive with your contractors so that every homeless person that gets dropped off by HPD or, county police gets served or moved into a place where it's safer?
We're trying.
Well, what are you trying to do?
We are trying, but with the number of vacancies that we have right now,
So what have
we
you
are
done?
doing the best that we can.
What have you done?
So we've been doing outreach. We participate in different meetings with different agencies. I definitely would say that we could do much better.
Could you give us a report of what you've done and where
Sure.
you are and what the challenges are? Because that's a major problem in the community, as you know. Thank
okay,
you.
other
Thank you.
question, Senator Favela, and then followed by Senator DeWitt.
Question is, you guys are talking about public safety and how much of the patients you guys have that have anything to do with criminal background?
Good morning. Kenneth Luke, I'm the administrator of Hawaii State Hospital. Good question. All of our patients are forensic, but I did want to go back, if I may, Senator. And want to start off with by saying I've been around for 30 plus years in the mental health field in Hawaii. And I think the public, the legislature has always been very generous in providing money to help out with the mental health system. But unfortunately, the population is growing, the needs are growing. I wanted to say that The end of 2020, Hawaii State Hospital had 245 patients. The end of 2023, 3 years later, we're at 375. So that's a 50 some odd percent just in 3 years. The society, the psychosocial determinants of health have gotten much greater. So 70% of our patients admitted are homeless. 82% have substance use issues. The majority, 2/3, are coming back to us because they failed in the community. So somehow it makes me believe that the outpatient system, even though they do a good job, if you want to look at it, well, 1/3 do make it, 2/3 don't make it, and they have to come back. So that's what we're struggling with. If I can go back on what Deputy Director Tsuji was explaining, why I think the public safety, or they have a new name now, corrections and rehabilitation, and I think they're moving in the rehabilitation arena, so that's a good thing. Then they might not be able to divert patients. People who need to be at Hawaii State Hospital really should come to us, and we can be an on-ramp for care. But instead of an on-ramp, we're a parking lot. People take over a year to get out of our hospital, and the average length of stay for psychiatric hospitalizations across the nation is 1 to 2 weeks. So with medication, with time away from the drugs they may have been using, with the structure, most people get better in about 2 weeks. But we're keeping them for many months because there's no place to put them. And a lot of times the judges are trying to adjudicate what to do, fitness, restoration, evaluations. This is where people who have stabilized medically and no longer meet medical necessity criteria to be in a hospital, this is where they could go to such a facility to wait it out. They've been psychiatrically stabilized, waited out at public safety and rehabilitation until their court matters are cleared up. So we do have a plan. You know, I even though I've only been on for 3 months, we know that if we're at 375 today, we're going to be at 475 in a couple of years if we don't do anything. We have to beef up how we transition patients to the appropriate level of care. So we have 4 group home type programs on the campus that are meant to help people transition. They're ready to leave the hospital, but maybe not quite ready to be our neighbors in the community.
And what's your vacancy at the hospital?
We're actually over census, Senator. 297 is our licensed capacity. We're at 337 sleeping in last night. And that we have another 41 in other facilities, like Director Fink was saying, where the costs are coming from. We have patients in a facility in South Carolina, Columbia Regional Care Center, and we have patients at Kahimoho.
Your vacancy for your employees.
Oh, I'm so sorry. I misunderstood the question. It was 270, but we had another 112 positions, so to speak, that we got January 1. So right now our vacancy is about 280.
Okay, is there any partnership with Windward Community College? Because one of the things I've been telling Windward is they should establish some type of, mental health pathway, CTE, AA, and then that, it's right there, internship. We got to figure out more creative ways so that we can fill these vacancies.
They have been very helpful. Artis, the chancellor there, her first phase was to help us increase the professionalism of the people already working. So we had PMAs go through that, get certification, and we are seeing better professionalism.
So what's the projected numbers per year to fill the vacancies with the partnership with Windward?
We hope in 1 year we can get at least all of the PMA positions filled.
Sorry. I don't mean to interrupt, but getting confused. I asked you a straight question. How much people that should be in prison or have criminal backgrounds is on your facility? The reason why I'm asking that is because corrections want to do the rehabilitation. Why bring them to the prison? I would have the ACOs help you guys with assistance of securing these patients under your guys' vacancies, or talk to our governor. Right? You know, why talk to our governor? Because he like build all these Kahali homes, why you don't make some therapy homes there for them to transition to the therapy home to go back into the public? Because he wants to build that in days. So why don't you guys have a big campus? So the ones that don't need to be supervised and can be therapeutic, they should be in those homes, getting ready to go into society. But the ones that need professional security, you guys should start asking corrections so they can come help you guys on the securing and the rehabilitation of the patients. But if we're gonna keep talking about abandoned buildings, waiting for DAGs do this and DAGs do that, DAGs, I don't know, I don't think DAGs forever was ever good in building anything and doing anything. So again, my colleagues are asking you guys, how much money do you guys need for that building, this building and that building? But you guys keep telling me, oh, it costs too much money. They cost too much money, so let's go help sell some huli chicken or something. What's going on? We like to know how we can help you guys, and we still never get the answer.
That's where I think in the long run, in the next couple of weeks, you guys should develop something a little more concrete, or maybe you have it, but you're just not prepared. And then just do an info briefing with subject matter on the projections of where healthcare is going and how we can be more supportive to deal with the trend of forecasting.
We will, but I think I owe the senator an answer. 375 sleeping in. 140 don't need to be there.
But how many really should be in prison or in corrections? That's what he's asking.
Well, all of them are forensically encumbered. 140 don't need to be there. And literally, they're just waiting for a court hearing. So they could wait out in the community, but I think the judges want them confined. So that's where I think we're wasting. The hospital's expensive. I think we're wasting resources to keep the 140 there when there's
But
probably.
is that going to be a trend? Because then it goes back to what he's saying. Maybe we should some type of other facility while they're waiting.
I think it's a good idea. Yeah,
That frees up the beds.
great idea.
So you have lots of space in the state hospital grounds. And I'm just wondering what Senator Favela is saying. If you can get the Kauhalis built there, that's at least someplace for them to live as a transitional.
With a different purpose. Now
Yeah.
the purpose is
So they have a place to live to leave your facility, so it's not so high priced into something where it's, transitional, but it's still, you can watch them.
and then you
at
free
night.
up the beds.
Yeah.
So
I had
people
a
have,
little bit of concern, about mixing the.
but it's out on
No,
the,
Coming out of White
it's
State
out-
Hospital with,
it's going to be on other parts of your grounds.
What she's saying is Kauhali-like facility,
got it.
not the program. She's talking
Yeah.
about the built structure.
Structure
so that you can move,
that you had a
transition out.
DOH on the parking lot structure, those small little homes
Yeah.
like that,
Fair enough.
you
So
know?
the 140, since they are forensically, that means that they can either be put out on bail or be put out on supervised release, right? Because they're awaiting a hearing.
Yeah, they're
They're-
waiting for fitness restoration. They're unfit. So the court proceedings are suspended until they become fit.
But so if they are unfit, then they have to be in your facility. You're telling me the 140 are fit? And determining, because I mean, there's two types, right? There's you determine whether or not they are insane at the time of the offense, but more likely, in your case, it's whether or not they are fit to stand trial. So the 140 you folks have determined to be fit to stand trial and are just awaiting the trial.
We have determined it, but the court evaluators, the judges still have not made a determination.
So they gotta be in a confined setting.
Correct.
Okay, so we can't put them in a Kauhali because they gotta be in a confined setting because they are awaiting trial either by. So why can't we move them in a detention? Because if they were not awaiting trial and be mentally under a 704 determination, they would normally be in detention in OCCC. So if Can't we transfer them there so they will be?
Well, that's where I go back to. Maybe this should be a more thorough info briefing because we want specifically on mental health subject matter.
My
coverage.
colleagues understand, we're not gonna be able to Kahale homes and they're gonna be walking around like over here at Queens. It's still gonna be a controlled environment, but it's gonna be different than what you guys have now. I'm not gonna say leave the door open and give them the key. It's still gonna be controlled and run by the security and the facility in a security environment. But it's to free up beds, because if we can build this under the proclamation quickly, right, and implement these things, then the ones that is waiting 174,
So
even though they're gonna be supervised,
under the.
you still can build them because you can get what, magnet doors, you can have cameras, you can have ACOs that don't need guns to go over there and intern before they go into the major prison. I mean, there's all the stuff that can work out, but somebody gotta have a plan. Like Senator Moriwaki always said, there's need a plan.
I don't think that this is a new issue across the US or other places. I guess this is why I was going back to asking about trends. And this is a good example. How do we separate them?
Yeah.
How much supervision do they
Yeah.
need? Because certainly, yes, they're not ready to be out free yet. And needing a court hearing yet. It can't be. But I'm saying they don't need to be confined like they do. But what is the trend across the US? Have you guys seen anything that you could share with us?
Okay, maybe we should just take this offline to subject matter. You have specific questions about that? Because then, if you need resources to further flush out the plan and come up with something more definitive, then maybe that's the first step. I'm not quite sure. I mean, you guys should let us know what you need because we want to get ahead of this versus seeing tragic stories on the news.
We're a large enterprise. On any given day,
No, but not just your facility. I'm talking about statewide. What's the plan? Because it's going to have to be, some transitional housing sounds like that has some supervision. Sounds like it because it runs the gamut. And I don't know the exact percentages of all the different populations to warrant a capital improvement plan. That's something that you guys would have to kind of develop for us. And then what would the staffing be to manage all of that, those type of facilities? What's partnered? What's federally funded? What's the state's responsibility? That this sounds like a lot more in-depth, but needed and necessary.
And Neighbor Island people do want to have a treatment facility there that's residential and not just outpatient, which is what's happening right now. Yeah.
Yep.
thank you, everyone.
Go ahead.
So, I wanna jump to a different subject. The department says it's advancing plans for the eventual transition of operations in Kalaupapa and the management in Kalawao County. The work has been multidisciplinary and involves coordination with the Department of Hawaiian Homelands, Natural Resources and Transportation, as well as the National Park Service and County of Maui. What do these plans involve and how is the community being engaged in this planning process?
Right, there have been a number of efforts recently, and WAM has been very helpful in convening that. So there have been meetings of the key
Kicking and screaming.
There have been additional meetings of the key stakeholders to work through the planning process with some options being fleshed out. So there's first is from a jurisdiction perspective, kind of what happens to Kalawao County. Now, just to level set, but I think you probably already all know this. So Kalaupapa is Hawaiian Homelands. And kind of surrounding that is DLNR land. And there's an agreement with the National Park Service to operate it.
The peninsula, a little more than half is DHHL and a little less than half is DLNR. Is that correct? Or 30%?
The way I think about it is Kalaupapa itself, the settlement is HHL. That's Hawaiian Homelands, and the rest of the peninsula is dealing.
Yeah, but the old settlement is dealing on.
Yes,
Yeah.
yes. But the agreement is really the entire county itself.
Is managed by Department of Health.
No, it has an agreement with the National Park Service. Okay, so
No.
there's multiple agreements among multiple parties.
Yeah,
So then the Department of Health has an agreement with the National Park Service, right? For we are providing care within the settlement itself.
Yeah,
to the
so what I wanted
patients.
to just distinguish was the fact that you have two landowners,
Yes,
but then you have an overlay of the county, which is the Department of Health.
yes, yes.
Which the director is the mayor.
Yeah,
Of
they're
Kalawao
the
County.
they're really the
Yeah.
a county
Yeah.
of, I forgot the name, but
You're a county?
Yes,
Yeah,
Kalawao,
Yeah.
Kalawao County.
It's a separate county.
Yeah.
It's not Maui County, it's a separate
Yeah.
county.
under state law,
Yeah.
they manage the county,
Yeah.
that
Kalawao County.
specific county.
He's the
Yes.
mayor.
Yeah,
Yes.
he's the mayor.
Kalawao.
Yeah,
Yes.
Kalawao.
Yes.
So that's where we were trying to get
Yes.
everybody on the same page as to what is the state's position in
Yeah.
dealing with the federal government
Yes.
versus the two landowners and the county, meaning
Yeah.
you, Department of Health, having their own individual agreements.
Yes,
Because that's where it gets confusing.
right.
Because I don't think you guys knew that DHHL is considering going back to homestead.
So I
Right?
had that conversation with Kali, because it is Hawaiian Homelands, and he is very interested in getting community input.
Yeah, I'm
To
not saying
inform the
he's
future of the land.
interested. They were interested in it.
So
Definitive. Definitive.
when the last patient passes, right, then the Department of Health's kind of Kuleana will change because our mission was to care for the last patient there. Then it reverts back to Hawaiian Homelands to determine what they would like to do
But is that in statute?
with the land. So that
It doesn't end the county, right? You would have to come back to the ledge
Yes.
and repeal.
yes, and that's what we're working on now. Is there's discussion of does someone else take over the county? Does it join back with Maui County? And we've reached out to the mayor. So there are those conversations occurring.
All within the last 4 months.
In the last 4 months, we've reached the mayor, but have not met with the mayor. And we have,
Basically the Lahaina fire.
Or did we in Maui?
Yeah, I just wanted to make sure though, at the end of the day, there's
Yes.
a state position with this.
Yeah.
Because right now the feds are just kind of dealing with each one individually.
so for the future of Kalapapa, we are working on a
It should be
state
one
position.
agreement with the feds, not three.
I understand that. I don't know how, because they're separate landowners.
No,
So-
but we're the state.
And you're the mayor.
Yes, you are.
For now.
So
Okay,
at the very least, there should be,
You're
I can see
there.
different parts of an agreement.
yes.
But it should be one agreement so that we all know, we're all on the same page.
I think we're on the same page for the present, but I agree, we do not have a plan for the future, and that's what we need to do.
Yeah, but the future is now.
Yeah, it's right around the corner, right? Do you have only 8?
Because the problem, like what we talked about when we were there, is what's our obligation? Because should we be putting additional funds to at least save some of those historic facilities? I mean, we're not quite sure. And in the meantime, because we don't have an agreement or an understanding of where we're heading in the future, some of those facilities or historic structures are disintegrating. I mean, we saw them, some of them you can't even use anymore.
Yes, under the current agreement, where the National Park Service in there, as I understand, in their agreement with DHHL, the National Park Service is responsible, but their approach
But they don't
is
own
to
those
let
buildings.
things naturally basically decay or decline.
Oh, see, and I don't know if that's the state position.
No, I agree. So we're asking Hawaiian Homelands for what structures they would like to keep maintained. And as we identify those structures, while we understand.
Maybe, okay, if that's the case, it could just be a policy call. And we might just have to pass a bill requiring that certain structures are going to be saved. Because they cannot just be, that kind of discussion cannot just happen in a vacuum. Because this is bigger, it's quite historic. I think we were all touched when we got there. We
Yep.
saw, it was very meaningful. And we want to make sure that we can preserve history. And I don't like the federal government's approach into just say, oh, we're just gonna let it disintegrate naturally. I don't know if that's where we're at.
I think the challenge is too is that, you know, the federal government is making certain decisions that I think you as the mayor should be making. And I'm saying in regards to even residents coming in. It seems like the federal government has taken jurisdiction, which I believe you should have the jurisdiction based on being the mayor. Which in this case, you know, that's why I've asked, what is the engagement you're having? Because the land is under DHHL, colleagues or Director Watson has to do beneficiary consultation, which he has. So if you guys haven't had that within the last 4 months, basically, what is the plan going forward so that, you know, we able to help? Think we've addressed the situation on the repaving of the airport, the lighthouse that the state provided funding for as well. But again, what are those structures that we're gonna be responsible for? One, first and foremost, is meeting the needs of the patients and the safety, health and well-being. So I'm trying to get a feel for where are we? This month is Kalaupapa month. And I just don't want us to just blow right past it as we continue to address the fact that, you know, we're down to, I think, our last 7, correct me if I'm wrong, our last 7 patients.
Hi, Dr. Diana Felton. I'm the Division Chief for Communicable Disease and Public Health Nursing Division, and the Hansen's Disease branch is one of the branches in my division. So as far as future plans, we're hinged on 2 important topics right now. We're hinged on what does DHL want for the future of the settlement, of their buildings, of their area, and what will happen to the county. So far, we have been.
Okay, wait, I think that's where there's a disagreement.
Yeah.
It has to be what does the state want, not one individual department, because even within the departments, there's individual agendas and responsibilities statutorily. We want to look at what's the state's best interests. And I don't think it's responsible to just let one agency determine which structure should be preserved or not without consulting others, including things like SHPT or the governor's office or you know, the legislature. Because when we went there, we want to make sure that as much is preserved as possible.
I agree with you completely. I think we're stuck on going forward until we understand the future that DHHL envisions for the settlement. Or if that's what the state envisions, then that's a bigger conversation.
But you're the state. That's what she's saying.
So we are the patients. The Department of Health, our primary responsibility is the health and
What they're
safety of
saying
the
now is, oh, it's not up to us, it's up to the landowner. That's what you're saying.
Yes.
future that we.
Because you're not going to be there in the future.
Right.
Once the last patient has passed and we have transitioned our other responsibilities there, we will still be involved in some of the long-term environmental cleanups that will be ongoing, but we do not envision
So we
for the
don't-
role of the Department of
That's
Health.
where what's not presented to us is some tentative plan that shows that. What's the transition over back to the landowner? What's Department of Health responsibilities at that point and how long? What's DHHL gonna do as far as stepping up to the plate now that they have to manage their asset? What does DLNR do now that they have to be more proactive with their asset? We don't have that defined yet. And that has not been explained to us.
And we are in the process of defining that.
Is there a draft that you can present to the legislature before crossover?
So an update was sent to this committee of,
No, we want you to present it
okay, we can present it.
because it has to be a back and forth.
So I believe we did have a meeting with all of the different departments. And one of the next steps was really involving the mayor of Maui County, because we needed to make a determination whether it was going to be transitioned from the state over to the county, or if the state was going to, and just what they wanted.
No,
Well,
Debbie. Come up with the state plan, right? Just like when we have legislation, if the legislation said it's going to go to Maui, the mayor can testify.
So they just wanted
If
to be inclusive of having that discussion. However, Don had reached out to the mayor with the Maui wildfires. He was just a little tied up.
Yeah, we're
And
but we're
so-
not talking about like tomorrow.
Well, no, she has just reached, she was able to connect with him. And so she's trying to set up a meeting with all of the directors, including Dr. Fink, Kali Watson, Director Watson, and Director Don Chang. So she's trying to establish that meeting so that they can all be in this discussion to look at what are their interests. Because it really is, as you said, a state discussion, and all the stakeholders at the highest level should be in that dialogue.
And our disappointment was that this is all happening at the staff level. The directors are totally unaware of what's going on in these meetings.
The directors actually were all involved and either were there present, or their deputies were, or they had representatives who reported back to the directors.
No, but that wasn't the case when
Yeah.
when we had the meeting at Kalapapa.
No, not at Kalapapa. So that's why we had a transition meeting after, and we came up with the transition.
Yeah, I'm talking prior to
document.
WAM's site visit. It
Yeah.
didn't seem like there was any discussion at the top.
And
And
we
the staff-
understand that there was a request from the staff, and this is prior to our administration, so we can't speak to what's happened in the prior administrations. But in the prior administrations, the directors were not involved in those meetings, and they had been asked, but they just chose to,
Delegate.
yes. And, you know,
So that's my problem. If you can delegate it, then the delegation should get back to the director, and then the director should come up with a plan. Because when we went to Kalaupapa, literally was work in progress. We're going to be reaching out. I mean, everybody know the wildfire had taken precedent, but at the end of the day, so shall the patients of Kalaupapa. So my question again is, what is the plan and what is the engagement that is taking place, irregardless, because Laura was there in Kalaupapa.
Well, and you cannot necessarily in this
Yeah.
case use the fires as an
Yeah.
excuse. Just because, I know you cannot speak for previous administrations, but this should have been in the works for years.
we understand that.
So that's where I think there was some frustration, is that why only when the committee started to do the site visit that it seemed like there was now, we're urging you to get a plan that's a lot more, solid that we can review.
And we understand that. And so that's why we did our best to at least identify all of the things that were within our control, all of, especially the environmental issues that needed to be addressed. We did try to engage DHHL in identifying what structures they absolutely wanted to preserve. We have been talking with NPS. NPS has preserved a number of those
So
structures.
that's where I go back to, if you have a presentation that you can show the legislature, just say, this is what DHHL wants to preserve, and we don't agree, we might say, no, we think we need to preserve more.
I would suggest that you approach DHHL about, because that would be out of our purview. We have to make that request.
He's the mayor. Director Fink is the mayor. He needs to coordinate that, which is why I'm asking, how are you guys doing the engagement? And if he feels that it's something that he cannot do, that's why he gets staff to work on some of this stuff, just like most of us. We're trying to help the situation. And we just started session, so we're trying to figure out which part of it that we're gonna commit to on our side. But if I don't know what the strategic plan is, just like with everything else was presented here, I don't know how to help. And I don't know how to.
And we need to
reach
put
back
money in
out.
now for certain structures. That's the issue, is that there is a sense of urgency that some of the structures are really falling apart, and they're going to be too hard to save soon.
And we have tried to identify some of the key structures that we felt needed to be somewhat preserved.
Okay, is
And
that
that's
in
what
their
we had
budget
been-
requests?
So that's why where we requested a general laborer and a plumber, because a lot of this stuff is infrastructure that's needed. And then beyond that, we did have a transition document that identified the key environmental issues, which are the things that actually need to occur first, because those are more health and
So a
safety.
plumber and a laborer is gonna fix something that's
Well,
crumbling.
no, you know why? Because
No,
some
this-
other structures were deemed asbestos. And those were not able to be worked on, and the ones that were needed special conditions, which is why it basically had to be inspected, cited, and then whether or not we could go forward.
Yeah, well, that
Yeah.
could be flushed out
Yeah,
in a presentation
exactly.
so that we can go
And
over
what
one
we
by.
did ask for was, we asked for an assessment, which unfortunately I don't believe that we got, but that's one of the requests that we had was a special assessment to look at all of the structures to identify which ones actually can be preserved, because that's beyond the scope of our expertise or anything that we would be able to do in-house. So we wanted to contract with someone who could come in.
So you have asked for that.
We requested it, but I don't believe it got into our.
Okay, what's the latest agreement between the three departments now?
So right now, we are waiting to, I have the Department of Hawaiian Homelands identify the different properties that they
And
would
what's
like
the
to
deadline you
preserve.
gave them?
We wanted it as soon as possible.
When did you guys meet?
The last time we met was about maybe 3 or 4 months ago. It was
So
prior to,
you only met once since we went there then.
and yes.
Okay.
Sure.
And we, because the plan basically that we submitted to, or the document we submitted to you, that transition document, did identify the steps that we could take in the interim. We were informed that the DHHL does want to do their community engagement, so they don't want to make any decisions until they do the community engagement. And so we don't want to put the cart before the horse. We want to give people the opportunity to weigh in.
Okay, but Chair, see, you're not listening. So when we was there, I know you was there. Senator De La Cruz said, you guys never did, Senator Lynn said the same thing. Every year since you guys been there was no maintenance. Some of these places just need paint, cutting grass. Where is that?
Fix the roof before.
Fix the roof.
Hard.
Do that kind of stuff. But none of that was said to us as legislators. I've been here 5 years. Never seen it inside the Department of
Yeah.
Health's budget. There was not one weed whacker asked for, nothing, not one paintbrush, not one maintenance plan on the buildings that is there. Reason why it disgusts me is because this is our people that went there and suffer and died, and that's how we took care of their remembrance. So I understand you guys like be calm. I cannot be calm because exactly what Senator De La Cruz and Senator Lindsey Quaid said. She been representative. She been around a while. She never ever heard anything of fixing up anything on Kalapapa, regardless if you guys just started. If you guys went there, you guys seen the paint peeling. Then as soon as you got there, Mayor, should have said, hey, do we have a paintbrush? No, that wasn't the priority because it's not really your people. That's what I'm talking
But
about.
when was, that was the first time you went there since you became director?
I've been there a few times.
2 times.
Yeah.
So I have a listing of the current and future projects, CIP projects. We have current funded CIP projects in process right now for repair and improvements. Couple $1 million. We're re-roofing a couple of the important buildings, the care home where the patients live, the storage facility that brings in all the supplies.
So yeah, but those are critical need facilities that you have now. What we're talking about is some of the abandoned facilities that are historic.
Yep, so the critical need facilities are taking priority, the places where the patients live and
That's fine,
experience.
but there was no ask for some of the historic preservation.
There has not. We have been focused on the current needed facilities.
And the other thing that we needed to take into consideration, which I was educated on by, I guess, the departments that have had to bring in construction materials, is that there's just a certain amount of work that can be done at a given time. And so in order to contract people and bring in supplies to be able to do some of these things, it's related to the barge
That's true.
situation.
No, that's true,
So-
but if we started sooner,
Right, again, I cannot speak to the past administrations. We are all, I would say, in the same boat of frustration that some of these things weren't addressed earlier. We're doing the best that we can to try to catch up, and we do make it a priority because I will tell you that our staff are very dedicated to the patients there and to Kalawao County. They really do, many of the employees there are from that area. And so there is a lot of care that goes into what happens there. So it's not that we're ignoring it. And I think everybody's very sensitive to.
so when is the next meeting?
So we were waiting for the next meeting based on the meeting of all of the different directors with the mayor. So that's what we're waiting for right now. We're hoping will occur.
The problem is, if because this is really the state, we shouldn't be waiting. We have to keep moving, and if when they can catch up, they can catch up, but we got to keep moving.
So at this point, what we're getting is we're hearing from all of the directors that they're ready to come to the table and really look at some of these issues. But again, there are people who they want to get that community engagement. And I think that's been really more the challenge is the time it takes to get that community engagement on the DHHL side. So,
Yeah, I don't think that should be the scapegoat though, but that's fine.
Because if you guys already know what the issues are, those issues should already be shared prior to even the engagement. Because I talked to a lot of the workers down there, even when we buried Uncle Boogie, I can tell you it was horrible. Okay. Number one, you guys put him in the wrong place. Okay. Then you guys have to re-dig him up. And let me tell you, that wasn't nice at all because the families were pissed. Okay. So these are, I think, basic things that have been overlooked. And irregardless whether you came in under the new administration, most of the people were still there within Department of Health. So was it just left not to do anything? So you know what I mean? You don't need to say nothing because all I know is the next budget coming in July. And we're not going to get one out of budget the following year. So why haven't the reach out been, okay, you know, we're setting 3 different dates for us to meet.
Yeah.
And let them choose. I mean, that's what we do. Like when we get together, hey, we're going to set up these dates. You guys, what is the best
We have,
date?
like, for instance, we
We
have
gotta
the
move.
legislative
Yeah, like,
calendar. We got to meet the deadline. It's constitutional. So she's almost saying the same thing. You have barge dates. You cannot move those. Those are critical. Prepare as much as you can so that you can utilize those dates and get as much equipment or whatever supplies or being proactive about it sooner rather than later.
And I take responsibility for that. I mean, I could have set up some set dates ahead of time and set those deadlines. And I apologize that I did not. I was waiting on that meeting. It did get deferred and things just fell off the calendar for me. So we will set some dates up specifically so that this does move along.
And I'd be more than happy to show up for those dates as well.
Thank you.
Thank you.
Okay. I'll go ahead.
Yeah, go for it.
Yeah, is OMCCR here?
Right there, Michelle.
Oh, okay. Hello, Michelle. So, I have some questions about Act 263, which was House Bill 1359, the hemp bill that was passed last year. It is your shop that's in charge of implementing the rulemaking that's required via the bill, right?
Correct. Michelle Nakata. I'm the chief of the Office of Medical Cannabis Control and Regulation. And it is correct that the Department of Health transitioned hemp processing and hemp product oversight to the medical cannabis program last year.
Right, because I think there's some general confusion in the community as to what the current status of hemp regulation is. The bill Act 263 last year mandates that you guys have to do rules. What's the status of the rulemaking right now?
The rules, as I understand, and I might have to ask the dispensary licensing section supervisors to step up. It's my understanding that they are currently in final draft form and the section is working with our deputy AG assigned to our program to put those into final form. We do have interim rulemaking authority. And so the intent would be once the rules are approved by our deputy AG and in final form, they will go to Director Health for approval. And at that point, they will be transmitted to the Lieutenant Governor's office per process.
When? Hello.
Good morning, afternoon, sorry. Thank you, Senator. I'm Liam Dimon. I'm the supervisor for the Office of Medical Cannabis Control and Regulation. Thank you for your question. We have been working on the rules. They are being reviewed by the Attorney General's office at this time. There was some delay with the review of the rules because that section of the Attorney General's office was handling their new adult use bill. So that slowed everything down. We're just waiting now for final review. We should get it in the next couple of weeks, I imagine.
So there is a, part of the governor's package, a hemp administrative bill. Is that part of,
No, ma'am, that would not, that's a separate.
Director Fink, are you, you gave me a list, and one of them was hemp,
Yes, there was a cleanup bill for cleaning up some of the language.
but it
of the
has
bill, but
nothing
it's
to do with administrative rules?
correct.
Yeah.
It does not have anything to do with the administrative rules.
So have you guys used the money that was appropriated in the bill to hire the consultant and the toxicologist to develop these interim rules?
No, the consultant and the toxicologist are different parts of that rules. The consultant is being hired by the Department of Agriculture. They'll be doing that. That is their task. Our toxicologist will be through us and will be set up. We have an RFP that is also being reviewed and ready to be signed at any moment after the review.
Wait, so those weren't to provide expertise to do the rules?
They were to provide help with the whole system for the hemp industry in the state of Hawaii. But the rules were different.
Okay, so we should expect some clarity on the rules here. Really soon.
Correct. And I'm sorry for the delay. It was pushed back due to the adult use bill.
So part of your overtime expenditure in table 13, you spent 38.3% of your budgeted salary on the OMCC rules and regs. I mean, is this the rules and regs you guys are talking about, or why is it such a, that's almost 40% of your salaries? Why is it so huge?
We have, we pay overtime to another Department of Health employee from the environmental health program, who is particularly skilled in drafting administrative rules, and she basically does all the legwork for us. That, I mean, that was the reason, that was the way that
The 40% was for this one employee.
it shouldn't have been. I have to go
that's for
back
the
and
entire salary.
calculate.
That's 40%.
Yeah, it's
for the
it's
entire
it's a
budgeted
substantial
salary.
amount. I think it's,
It's tape.
I will go back and take a look at those figures because I suspect that that's not correct. It's not that much. I think it's, if I remember correctly, for the overtime requests that I've been signing off, it's $5,000 per quarter. So it should have been $20,000
Yeah.
per year.
Well, the base salary is supposed to be 63,000, but then the overtime is 23,000.
Okay,
So that
this
comes
is
out-
for the individual that we are, we're paying overtime to, right? I mean, this is, she is responsible for, helping us with drafting dispensary licensing rules, which we were able to do 3 or 4 in the past round, updates in the past year and a half. She's also helped us with registry rules, and now she's helping us with
With the hemp.
Yes.
So, and the reason, Senator Keohokalole and I are concerned is because, you know, the adult use bill includes hemp regs. So is the same Attorney General reviewing your hemp regulations so that there shouldn't be a conflict between, should we pass the adult use bill with the existing hemp regulations that you folks are putting forward as part of the administrative bill?
Yes, so the Deputy Attorney General that's assigned to the Office of Medical Cannabis Control and Regulation is the same Deputy Attorney General that was assigned to Department of Agriculture and specifically worked on ag's hemp program rules. He's since moved over, and we have him as our full-time assigned.
Well, I think the point here is that a lot of the community angst about legislation that we may or may not pass was around what is perceived to be a new idea of uniform regulation of cannabinoids, that hemp and cannabis are going to be regulated now. If the bill passes, hemp and cannabis will then be regulated uniformly by the same state entity in the Department of Health. But I guess the question is for you to confirm for us that HB 1359 last year actually already centralized regulation of hemp and cannabis together in the Office of Medical Cannabis Control and
Okay, so
Regulation.
just to clarify, the hemp program was previously assigned, it's always been assigned to the health department, right? The processing and the hemp products. It's always been assigned to the health department without specification as to the program. The Department of Health chose to place that regulatory responsibility under the Food and Drug branch. And that responsibility was reassigned to the Office of Medical Cannabis Control and Regulation last year.
Well, so I think we're getting in the weeds to the more, and this is my fault. What I think would be more helpful is for you to confirm that the Department of Health has always uniformly regulated hemp and cannabis.
Correct.
And that the rules that you guys are about to publish uniformly regulate hemp and cannabis. So uniform regulation is happening no matter what.
Yes. And actually.
But you say it, so it's on the.
So yes, and actually hemp rules were changed last year to clarify the requirements. The changes that we're implementing in this round of rules are additional, they're not substantive changes. I'm sorry, I would have to ask Liam to explain what the exact changes are, but yes, everything is being done by OMCCR now.
So regardless of whether or not this bill, this adult use passes, there's still gonna be this uniform regs anyway.
Correct.
Okay.
They will exist regardless of where the hemp processing, the only problem that will happen is if there is legislation that's passed that separates it, so separates out the hemp product program out from the adult use program and tries to leave it behind with the Department of Health.
There's no existing legislation.
Okay,
We're
that's,
talking
I
about
mean,
the existing
okay,
one.
I'm sorry.
Well, I don't want to talk about what we may or may not pass into law. The question is, you're asking for resource in your office to do cannabis regulation. And we gave budget last year for you folks to do uniform regulation of hemp and cannabis, in part to deal with the Delta 9 situation in Waikiki and some of these other instances where there may have been shady characters operating in the CBD space or in the hemp space that were essentially, supercharging their products so that they're on par with medical cannabis type products.
Understand.
And the question is where that is and why you need the money going forward if you're about to publish the rules anyway.
Okay, so Liam can probably explain the hemp rules better than I can because the current staff that are addressing hemp now work under him. But those two things that you were talking about, whether we've moved forward with recruiting and hiring, the toxicologist was, as I understand, to help with the rules. The specialist or that other position that Department of Agriculture is hiring, as my understanding, was to convene a task force and to support the work on that with the task force. It was not pertaining to the rules.
Okay, and so how many task force meetings have you guys participated in?
The Department of Health is actually, we're not involved with that because we're actually not even, as far as I understand, we're not even named as members of the task force.
Yeah, but you guys are the regulator, so you elected not to participate in the hemp task force?
Sorry, no, there's some misunderstanding. So the Department of Agriculture has been tasked to develop the task force. Makes sense. To develop the task force for the hemp proceedings. They are the ones who are establishing that. They will fund that. They will control that. They have just recently released their RFP to hire a consultant. The consultant will be the one that will set up the task force and the task force meetings. We've been in talks with the Department of Agriculture and have offered them our assistance because there is a level between industrial hemp and cannabinoid hemp. And that's where we want to make the distinction of what's going on. And that's a common misunderstanding that the Office of Medical Cannabis Control and Regulation, we regulate the cannabinoid hemp part of it. We do not regulate any part of the industrial hemp industry. So hempcrete, linens, ropes, things like that. Anything that's made with the regular plant, that is not under our purview.
Okay, but you haven't been participating in the task force because the
There
task
hasn't-
force hasn't been convened.
Correct, sir.
Okay, but you do intend to
Oh,
participate?
yes.
Yeah, thank you.
So the uniformity across the board, will the uniformity regulation also include edibles?
It will. And there are some little idiosyncrasies between hemp and cannabis. But yeah, we're trying to get as much in line together. And that's part of the reason why the rules have taken so long, because some of the testing will be a little different, have to be tweaked a little bit. But we want to have it so it is basically the same.
Who will do the inspection of the edibles at the THC levels?
So for hemp products, it will, for hemp products or cannabis products, it will be my office, it will be my surveyors from the Office of Medical Cannabis Control and Regulation. We do not have the rules in place and the actual proper steps that we're going to use. Once the rules get finalized and it's signed off, we have a plan that's ready to go.
So I got a question. I was at a conference 2 years ago. FDA was sitting there, we had a doctor, and we had one legal marijuana oil that was registered by the FDA.
Correct.
I have not seen any other legal marijuana that is registered by the FDA.
You are correct in that. There is, and actually there was a hemp-based cannabinoid, or probably what you're thinking about is the juvenile anti-epileptic medication that has been used to treat juvenile epilepsy. And there has not been other testing, other drugs. The problem is the schedule, cannabis is a Schedule I drug. There has been talk recently by the Biden administration to deschedule it down to a lower level to make it open and more available for scientists, doctors, academics to study the effects, to promote different types of drugs.
So how is it that we only get one legal registered marijuana on the market by FDA? So are you telling me everybody else is illegal? That we are going to approve the usage of marijuana, edibles and so forth, not being backed by the FDA?
So the FDA considers cannabis a Schedule I drug. And for that to be approved across the nation, across all the states and territories, it has to go through a very strict process by the FDA to get approved. To do
10
drug
years.
approvals.
10 years.
Oh, yeah, and millions of dollars. And it's,
You know what we were told? You know what it cost him to get it registered? $1 billion.
I believe that. And it is, and that is very much keeping smaller pharmaceutical companies out. And we could talk about this for.
Well, I guess what I'm asking is that if we're condoning it, what happens if the individual dies that it's consuming it because we haven't figured out what is the right percentage usage, would it be for the child, middle age, or the adult? Who's liable for that at that point?
That's a very good question, and I don't think that has come up with any of the states that have legalized medical cannabis. Michelle, do you have any ideas about?
Well, why is that? Is that because of the draw of the money for the states, or is it?
No, I
It's
think
like-
there's a very rich history about cannabis. There is a very strong bias against people of color in cannabis, and that's originally why.
Well, I kind of look at them as a safety. I
Yeah.
mean, I'd hate to like say, you can use this in as Senator Cololis, the different strains that are out there. I mean, will have different effects on those individuals that are consuming, let alone the oils that are out there, which, I mean,
Yeah.
for some it's helped. I just trying to figure out what is the liability to us as a state.
Well, it's very good questions, and I appreciate them. And I think our strength in our state, and most of the states that allow medical cannabis, is that we have strict rules and regulations about testing the products, the strength of the products, who's allowed to have it. You have to be under the care. You have to get a qualifying physician to qualify you for it. So it's not adult use. When adult use comes around, if it does get elected in, that'll probably be a much better question for them, because I think now that we have a number of safeguards in place that they have to be packaged in black and white packaging and labeling, so it doesn't look, children won't want to take it. It has to be childproof packaging, so you can't open it.
I see
Control.
gummy bears that ain't childproof.
Roger.
It looks so good to eat. If you pop some
That's-
limoy on it. I mean, I
That's
can
why we did
eat
the
it.
bill. Hemp.
I-
That
That's
is-
why we did the bill.
That is
like-
very much hemp, and I agree with you. I've seen some very appealing products in the hemp industry that children will eat, and that is, and the
Okay.
packaging, there's no rules or regulations.
Okay,
about
maybe this is a
packaging for
subject
hemp.
matter info briefing.
Sorry,
Yeah.
yeah, but we could talk about.
Yeah.
if you'd
Okay,
like
I
to
know,
talk-
we probably, like, I still
Kind
got
of like
like,
blown away. We just don't get
pages
one
of
registered by the
questions.
FDA. That worries the heck out of me.
but I'll just send it in a memo. Okay, we're gonna adjourn. We're gonna take half an hour so that people can have lunch, and then we'll go back, we'll go to DOTAS. But I just want to thank you. This is probably one of the better PowerPoints that I think that we've seen. So you, or at least were proactive in showing us your challenges, especially with the vacancies, and some of your requests. So thank you. Okay, adjourn.
Thank you. So, what are you gonna do?